All right, now we hit resistance, pressure, and flow. I know equations are painful, but your test question writers love equations. And the concepts behind the equations are even more important. So write these out with me. We'll start off with that pressure, or the change in pressure, is equal to flow, which is Q times resistance. This looks a lot like Ohm's law that is applied to the flow of electrons through a conductive medium. Now pressure is just a relative term, just like voltage. We're talking about one area of pressure compared to another area of pressure. So the pressure from this upstream location, P1, in a vessel only means something relative to the other location further downstream. The difference between P1 and P2 is actually what drives fluid flow. So we will consider the two components of perfusion pressure. This is volumetric flow rate and the resistance. We will start with the resistance. Resistance is equal to 8 times the viscosity, which is this funny n, times the length of a vessel divided by pi r to the fourth power. R is the radius. This symbol here is eta. We're going to say it's viscosity, so don't worry about that. Now, if you increase factors here in the numerator, such as viscosity or the length of the vessel, you create a proportional increase in the resistance. So the resistance is going to go up if you increase any of these. I can't think of any situations in which we're actually going to lengthen vessels, so don't really worry about much of the L part, or length. Let's examine viscosity and the radius because they're those two factors that are big time and we can control those. So viscosity is the intrinsic ability of blood to flow against itself. So visualize blood flowing in a vessel like this. Bunch of different arrows of flow within a vessel. Here's our vessel. It's like a bunch of arrows flowing stacked on top of each other. There's going to be friction in between all of these layers. So how can we increase viscosity if we're talking about blood? Well, if we increase the concentration of stuff that's in the blood, we increase the interactions between each of these flow vector arrows. Now, some great examples of this would be increasing the number of red blood cells, and we see this situation in polycythemia. Or we could increase the number of proteins in the blood. What kind of situation are we talking about with that? Well, that could be multiple myeloma. Now, on the contrary, we can also decrease viscosity in a situation where we not increase, but we decrease red blood cells, and that's anemia. So anemia can actually lead to a flow murmur because of the turbulence created because of such high velocity due to low viscosity. Now, another important thing to remember is that the most important factor in this equation is actually the radius. That's why it's to the fourth power. Arterioles are the ones that are responsible for resistance. Arterioles are the ones that precede capillary beds. They are the key players in regulating the total peripheral resistance. Note how they do not have an influence on venous return. Now, why is that? Well, most of the blood in our body is within our veins at any point in time. Your book mentions that vessels can be arranged in series or in parallel. Now let's go a little bit farther into that real quick. So we were talking about a series and a parallel circuit arrangement of vessels. Now both series and parallel usually occur at the same time within an organ. So let's hear it. Draw an arteriole, and here's a capillary bed provided by the arteriole, and here is the venular side. So arteriole and the venular side, and then there's going to be a capillary network that's multiple small branches within this capillary bed. Notice here that the arteriole gives off multiple branches. We'll label these 2, 3, 4, and 5, and we'll label this 1. So this arteriole is in series with every single one of these tiny branches, but these tiny branches are in parallel with each other. So this is an important concept. The large single arteriole is in series with these parallel arrangement of small branches. So if we want to determine the total resistance, which is TR, we have to add the resistance of the arteriole, which is going to be R1, plus the total resistance of this parallel circuit. Now this is going to be R2 plus R3 plus R4 plus R5. So let's say the ones in parallel each have a resistance of 8. And we add these up, we get 1/8 plus 1/8 plus 1/8 plus 1/8 equals 4/8, or 1/2. Now we have to add this to the resistance of the original arteriole that supplies this whole capillary bed. And the resistance here is 5. So 5 plus 1/2 equals 5.5. This is the total resistance of the circuit here because it is composed of series and parallel arrangement. Most organs of the body exist in a parallel circuit with each other, which is why removing an organ like a kidney is going to severely increase the total peripheral resistance because we're going to eliminate a large parallel circuit and therefore drive up the TPR, or total peripheral resistance. Now we reach these cardiac and vascular function curves, which seem rather confusing because they have two variables on the x-axis and two variables on the y-axis. So first of all, let's just talk about here, where the red and the blue lines intersect. This is the operating point of the heart. It indicates where venous return equals cardiac output. So the cardiovascular system is just one big closed loop. Anything you pump forward as your cardiac output is going to come back as your venous return. So first, let's talk about diagram A. What is meant by inotropy in the first place? Changes in inotropy indicate changes in force of muscular contractions independent of preload. Remember, we talked about inotropy being related to the amount of intracellular calcium. This is the reason why the tripoint here at the origin isn't moving. Preload or end diastolic volume has nothing to do with inotropy by definition. So things that increase or decrease inotropy will not shift anything on the x-axis. Things that increase inotropy can be considered in your mind as anything that increases intracellular calcium in a cardiomyocyte, because that leads to more exposure of myosin binding sites on actin. This results in increased force of contraction. Now, if you look at the curve labeled with a 1 here, we're talking about sympathetic nervous system activation and digoxin as both ways that we can increase inotropy. Digoxin is a positive inotropic agent. Both of these positive inotropic agents increase intracellular calcium, but they do so by different mechanisms. Remember, digoxin inhibits the sodium-potassium ATPase to obliterate the gradient for the sodium-calcium antiporter, so that we increase the levels of intracellular calcium. On the other hand, sympathetic nervous stimulation increases the activity of protein kinase A that eventually leads to opening of the L-type calcium channels, which leads to more intracellular calcium. One more thing that the sympathetic nervous system does is it also increases efflux of calcium from the sarcoplasmic reticulum. Either way, in both cases, we're going to increase stroke volume, and therefore we increase cardiac output, which shifts this curve up. So again, positive inotropic agents shift us up. Now what if we wanted to shift the other way, down, in a negative way? Situations where we're talking about is uncompensated heart failure or a narcotic overdose. These are listed here because they both result in a decrease in cardiac output. In uncompensated heart failure, you decrease your cardiac output because some of the compensatory mechanisms such as the renin-angiotensin-aldosterone system, the sympathetic nervous system, and the Frank-Starling mechanism have maxed out. They've been worn out. They no longer help. Therefore, we've uncompensated. The heart's decrease in stroke volume is now very profound. Now, in the case of a narcotic overdose, we directly suppress the cardiopulmonary center in the medulla. That's what opioids do. This causes a severe decrease in the heart rate, which makes your cardiac output drop, right? Remember the equation, cardiac output equals heart rate times the stroke volume? So now we've affected one of the factors. So in summary, both have a decrease in the overall cardiac output that shifts our curve down. Now in uncompensated heart failure, the main mechanism is a drop in stroke volume, while in narcotic overdose, it's mainly due to a drop in the heart rate. Next up, we discuss venous return. Let's cross out vascular and write venous, because that's what we're really worried about. Before we try to analyze the graph and the different shifts, we need to remember several key points. Number one, venous return is determined by the pressure gradient by this equation. Venous return equals venous pressure minus the right atrial pressure. And number two, mean systemic pressure is the pressure that would force blood back into the right atrium if the heart was not beating. It is therefore only dependent on the amount of blood creating pressure in the arterial and venous circulation. Number three, most of the blood in our body is in the veins. Most of the blood is in the venous system. This means that changing the mean systemic pressure will only occur as a result of changing venous volume or changing the distribution of blood in the venous compartment. Alright, so again, here's our equation. Venous pressure minus right atrial pressure will tell us how much venous blood is going to return to the heart. So anything that increases venous pressure, such as an increase in venous tone, or anything that decreases right atrial pressure, such as the negative pressure created from inspiration, will also increase the return of blood to the heart. Now in your book, here at number 3, we're talking about IV fluids. So a bolus of fluid will increase the venous pressure because it increases the amount of blood in the venous compartment. This will increase the blood return because the difference between venous pressure and right atrial pressure will be much greater, creating an increase in the venous return. In a similar situation, the sympathetic nervous system will lead to alpha-1 mediated venoconstriction. This will also increase the venous pressure, driving up the gradient for blood to return to the heart. Both lead to an increase in venous return and therefore will increase cardiac output because we're increasing the preload. Notice how we're going to shift up and out. Now under the number 4, we have bleeding or acute hemorrhage and spinal anesthesia. These are the exact opposite of giving someone a bolus. IV fluids is the exact opposite of bleeding. And activating the sympathetic nervous system is the exact opposite of spinal anesthesia. In acute hemorrhage, we actually lose a bunch of volume. This leads to a decrease in the venous pressure. This drop in volume leads to a decrease in the venous return to the heart. Now what about spinal anesthesia? Well, spinal anesthesia is the exact opposite of sympathetic nervous system activation because the anesthesia can numb the nerves that coming out of the spinal column responsible for the alpha-1 mediated venoconstriction that we want, but because of the anesthesia, we're not going to get that. The end result is also a drop in the venous pressure, and therefore a decrease in venous return. Alright, now let's continue and move on to examine diagram C. This shows our cardiac function curve in the dotted red and the venous function curve in the dotted blue. Now total peripheral resistance is mostly determined by the arterioles. Remember we said that on the last couple of slides. So if you increase the resistance in the arterioles by decreasing the diameter using a vasopressor like norepinephrine, the heart will have a more difficult time pushing blood out against this new resistance. This equates to a decrease in cardiac output. We shift down. So why does this also rotate the venous function curve down and to the left? Well, a drop in cardiac output means more blood stays in the heart. So less blood will need to return to it for the next cardiac cycle. So for this reason, our venous function curve shifts down and to the left. Note how this is not actually shifting the curve because the x-axis stays the same. There's no change in the x-intercept, which is our mean systemic pressure. Now, mean systemic pressure does not change when we alter total peripheral resistance because increasing the tone of arterioles does not significantly affect anything about the venous compartment. Now, what about the situation of exercise or an AV shunt? Well, in the situation of exercise, we're going to have increased beta-adrenergic activity on the heart. Remember, we're going to increase inotropy by increasing intramyocyte calcium. This is going to shift us up because we're going to have more cardiac output. Now, how do AV shunts cause an increase in the cardiac output? Well, let's look at one here. This is an arteriovenous malformation or fistula in which the artery is directly communicating with the vein. It is not normal for one single vessel to directly connect the artery and the vein directly because we end up bypassing the precapillary arterioles that are responsible for determining the total peripheral resistance. Without these arterioles, what's going to happen? So here we have an arteriovenous malformation or a fistula in which the artery has an abnormal connection with the vein. Notice that there's only one single vessel connecting the two. It is not normal for one single vessel to directly connect the artery and vein directly. This means that we end up bypassing the precapillary arterioles that give us a significant amount of total peripheral resistance. So if we eliminate these arterioles, we drive down the resistance, and therefore that's going to increase the cardiac output because there's less afterload for the heart to pump against. So let's go back to our diagram. You can see here that this increase in cardiac output will shift us up, and at the same time, there's going to be more blood that needs to return to the heart for the next cardiac cycle. So this will shift the vascular function curve back and up to the right because there will be more blood returning to the heart to fill for the next cardiac cycle. So notice how we've increased the slope of the venous function curve.